Hello, my name is Jay Deedy, CEO of AwarePoint Corporation. AwarePoint is pleased to support the ACCE Elders documentary outlining the history of innovation and excellence in the profession of clinical engineering. AwarePoint also shares a history of innovation to support advances in patient care by providing the only complete RTLS solution, optimizing healthcare workflow. Picture all of the second-by-second movement of equipment, physicians, health professionals, and patients in a busy hospital's routine. Every year, AwarePoint tracks and optimizes this coordinated workflow for over 300,000 mobile medical devices and 1.2 million patients and healthcare providers. AwarePoint continues to innovate to create solutions for improving asset management and availability, optimizing patient flow, and increasing care team efficiency. We look forward to our continued partnership with ACCE to advance patient care through technology and clinical engineering.
Hi, my name is Mario Castaneda. I am the president of the American College of Clinical Engineering. I am now in my second term. I've been there for 2 years in this position, although I have been a member of ACCE since 2003 officially, but I have been supported for many years. The American College of Clinical Engineering is an organization that is at the center of patient care delivery with technology. Our ultimate goal is to use technology to enhance the healthcare of the communities. This is about technology bringing really the promise of delivering effective and lower cost healthcare. This country is one of the few countries that is struggling really having an ideal level of care. We're at 17th in the world in terms of morbidity and mortality. We can do better than that. And technology is one tool that we can use to get there.
We got to the moon using slide rules. We should be able to do a lot of things now with all the computers and all the power that we have for data manipulation now.
It's a very rewarding life role to play in the healthcare industry, and what you can do in improving technology, and through improving technology, improving the skills and abilities to promote healthcare.
As a foreign student, I could not just get a job in McDonald's, Wendy, or someplace like that. So I became an orderly. I was carrying patients in and out of the operating room. When they have a limb removed, I carried it to the laboratories, ran to the blood bank and brought the blood packs back, and realized that there are instruments and machines standing there at night in the operating room at a very critical stage of sustaining life, and nobody serviced them, nobody maintained them, nobody calibrated them, and it triggers stimulation on my part, and that's where I started clinical engineering.
In Chicago in the late 60s, early 70s was the center of the electrical safety scare. You'll recall that Ralph Nader wrote an article quoting 10,000, 15,000, 20,000 deaths per year from shock in hospitals.
It pointed out that we needed both biomedical equipment technicians to do the hands-on repairs, maintenance, preventive maintenance programs, and so on. As well as we needed someone to manage these programs, specifically the clinical engineers, who not only knew a lot about the maintenance program, but they also knew how to establish particular programs for a specific hospital, who could constantly make improvements in the programs. And these were interesting times where the technology was in fact moving from the research arena to the hospital arena, and there was a definite need for professionals, engineering professionals, technical professionals, to work with the hospitals to assure that the equipment was being properly utilized and safely maintained. And it was that impetus that pushed the development, or the evolution, if you will, of clinical engineering out of biomedical engineering. In other words, we had gone from medical electronics to biomedical engineering to clinical engineering, this natural evolution.
I really felt that the professional level of clinical engineering, both from an educational and practical viewpoint, was absolutely outstanding. By being engineers and applying principles of engineering to medicine and to the clinical setting, provided a stronger base, in my view, to that setting. And they also looked at things a little differently. They looked at them just as engineers or just as clinical personnel. But they looked at it from the standpoint of the two views and kind of modified the basic view into one that could be pushed a little bit further, a little safer, a little more effective through this common education.
Over the years, there have been professional groups that have recognized the involvement of engineers in medicine. The Institute of Radio Engineers back in the 50s started its group on medical electronics that later became the group on biomedical engineering. But they did not adequately support the actual hospital engineer practitioners, and so they pushed caused AMI to come into being that recognized both the manufacturing industry and the hospital engineering industry.
After several years of coming to annual meeting of ASHE and AMI and IEEE, EMBS, I start realizing there is a rehearsal of a common thread. We, the clinical engineer, were getting out, sitting in the benches in the hallways, complaining and whining. Nobody give us respect, nobody teach us what to do, nobody pay attention to us. And I thought to myself, if not us, who? So why don't we have an organization that is focused only on clinical engineering? And I started thinking about that, and we realized this is what we need. We need to create a professional organization that would allow us to focus all our synergies and energies and put it towards developing of a profession.
And so there became a growing interest in forming another group that would specifically focus on the role of clinical engineers in the hospital. And this group actually founded in 1990, I believe, as the American College of Clinical Engineering, of which I was a founding member.
This was probably one of the better steps that we've ever taken as a profession to get our name out and to get recognized.
One of the problems that we felt ACCE or clinical engineers faced was the recognition of their role and their importance in the healthcare setting. I would also develop one of the first brochures that says, what's a clinical engineer? The people hear, when they hear the term clinical engineer, it doesn't mean anything to them. And so that has been one of the roles of advocacy for clinical engineering by ACCE. ACCE has assumed a growing role with a certification program, producing a pool of recognized professionals. It has had a growing influence in the elevation of technology, safety, technology operation, the economics of the technology acquisition and maintenance over the years. And these are all things that I think hospital administrators, which were very resistant in my day to things that I wanted to do in our hospital. Today, I think hospital administrators are growing to recognize the value of clinical engineers in the hospital and the participation in technology decisions and operation.
The members held a high level mentally of what they should be accomplishing, and we're always trying to improve the safety and the maintenance levels in hospitals. This kind of captured me from the standpoint of being a member of this group, because I believed the same level should be maintained, introduced and maintained for the safety of the patients.
Today, 21 years later, I'm proud to see how great ACCE became, how complex the organization is. We're struggling with how to run the organization. That's great. That means there is growth and there's satisfaction, and that means that we were right 21 years ago to create it.
The American College of Clinical Engineering is about leadership. Our organization helped them be better leaders and also give them the skill sets and the tools to be efficient and contributors not only to the organization, their workforce, so to healthcare delivery in general. The current efforts for leadership from ACCE is obviously provide the latest information that we have, not only from industry, but also from the peers. We have a leadership summit. The goal of this activity is to bring the players in this new converged world. We have employers, we have vendors, we have the different professional organizations, and we're all going to have a dialogue of what is needed to move forward in terms of the leaders of this field. Because technology is changing so much, there's no longer talking about just the clinical engineering part of it. We need to talk about the IT, the information technology that goes with that. We also need to talk about some of the other pieces that come with that, like regulation, for instance, and new policies and government involvement. So getting everybody together to figure out what is it that we need in the future leaders is what this summit is all about. Also, we want to work in a specific situation that we have now, and that is there are many positions, very good positions that are open currently, are not filled for a long time. Positions as managers, directors, and vice presidents. So we want to make sure that our members have the opportunity to learn the skill set that is required to move from the technical side to the managerial side. ACCE is also about stewardship. A stewardship of patient safety. Now, in this new technology, we have many technologies coming together. We need to ensure that the patient is safe. We also want to provide the appropriate tools for the physicians and caregiver to give the appropriate care. Another part of a strategic direction for American College of Clinical Engineering is collaboration and partnership. Now we have a great challenge with the technologies converging. We need to work with other organizations to be able to resolve the complex issues that are resulting from mixing all these technologies. Organizations such as AAMI, HIMSS, ECRI Institute, the FDA, the Joint Commission come together and we form national summits as a model to look at the current issues, to look for the priorities, and really to prevent the problems of the future. One of the benefits of being part of the American College of Clinical Engineering is when you join, you will become part of a group of leaders in the field, not only on the big projects that are running, but also they run many departments of the major organizations in the United States and around the world.
Hi, my name is Tom O'Day. I've been a clinical engineer for about 43 years now. It's been my privilege to have done that and be a member of the American College of Clinical Engineering. I enjoyed working with the Northwestern and the Big Ten football teams. We worked on a project to instrument helmets to find out how hard football players got hit during the game. We even recorded one of the few actually recorded concussions during football season. That data was fed into by the Big Ten into a helmet manufacturer, Rydell, and they came up with a better helmet, which I believe is the basis of many of the helmets used today.
I'm Malcolm Ridgway, Senior Vice President for Technology Management at Masterplan, now part of Aramark. Like a lot of people in my business, I didn't start out wanting to be a biomedical engineer or a clinical engineer. I actually have a degree in physics and geology, and I was intending to be a geophysicist. And so at that time in the UK, if you didn't escape abroad or go for a higher degree, you had to go and work in the army. So it was really to avoid the draft that I got recruited into the biomedical engineering field. A random itch in 1966, I decided to come to the US and joined the space program, actually working on the lunar lander for a company called Bendix that was in Ann Arbor, Michigan. There were layoffs coming, so I moved into the USC Biomedical Engineering Institute. And it was while I was there that I got a grant from the Kellogg Foundation that really took me into the biomedical engineering field. In particular, in the 70s, I had a big part in the team that was involved in isolated power, and that was very satisfying.
I got started in clinical engineering back in 1964 after I was injured playing hockey, and I had to make a decision as to whether I would teach or be an engineer, because I had degrees in both engineering and in education. I chose engineering simply because of the money involved. I was involved with the federal programs for various defense and aeronautical and aerospace. One of the things I worked on for them was the respiratory support system for the astronauts. In 1969, when Armstrong stepped onto the moon, I was one of many people saying, breathe, breathe, because if he didn't, that meant what we designed did not work.
Another great benefit of becoming part of the American College of Clinical Engineering is that you will be at the crux, at the center of the information that is current and that is relevant in the field. We have several activities like symposiums that bring the brightest and the best together to provide information that is very much in accordance to what is going on right now. You also have the opportunity to look at the different vehicles that we have, like the newsletter and some of the information they put on our website for members only. But above all, you have the opportunity to talk to your peers, to the fellow members that may be going through the same situation that you are, and they have information that's very useful to you.
One of those first society meetings, I walked into the room and looked around me and said, wow, here's all these people, all these names that I see on publications and in books that I study, and I was overwhelmed just looking around me.
The specific support mechanisms, the specific knowledge, the specific creativity of these many individuals have been very helpful to me in finding solutions to problems that I have had. You know that you have a complete college, not only of men from the United States, but from around the world, who you can pick up the phone and call to get answers for some problem you may be working on.
As a member of the American College of Clinical Engineering, you can also participate as a speaker, as an active participant in many of the symposia that we offer nationally and internationally. Also, we have advocacy groups that work with the government and other policymakers. Internationally, we have placed 51 workshops throughout the world, and you can be part of that.
I have participated in workshops that have been put on by the American College of Clinical Engineering in I think something like 20 different foreign countries over the years. Spending a year in a country like that with the local people and living in the local community was just a wonderful experience, and we made many good friends that I've maintained ever since.
I've met a lot of very interesting and fantastic people. I spent time with Mother Teresa in India, and she asked me why I was doing this work, and I told her straight out that I was, my usual self, that I was looking for a cool spot in hell. And she looked at me and said, "You'll know a lot of people." I had a little impact on her thoughts, and she had a fantastic impact on my thoughts.
Well, I think probably my most favorite is dealing with people in foreign countries. Also, the work with the American College of Clinical Engineering with advanced clinical engineering workshops. I've worked in Russia and Nepal and Lithuania, Africa. In fact, one of my most interesting experiences was developing a biomedical engineering training program, or actually a bachelor's level program at the University of Riyadh in Saudi Arabia.
I always found that very exciting. Not only did you feel like you were accomplishing something from the standpoint of advancing other countries, but it was very satisfying to see what those countries were doing at that time and then watch as they made changes to make improvements.
I find also anytime I'm working with people at other places, I learn things too. I learn how they do things, and sometimes, I keep telling people that there are new things that can be done, and sometimes we're just reinventing old things, and so we need to learn from each other.
The mission of the American College of Clinical Engineering is as follows. First, to establish a standard of competence and to promote excellence in clinical engineering practice. Secondly, to promote safe and effective applications of science and technology in healthcare. Third, to define the body of knowledge on which the profession is based. And lastly, to represent the professional interest of clinical engineers. Technology in healthcare is going through a very interesting phase. Many new technologies are coming into the field. In the practice of clinical engineering, we had more control in the past, where we're dealing with what I call boxes. That means that the medical devices, were pretty much independent and unique. Now they're connected to each other. Now IT and informatics are coming very heavily to connect all these boxes, and the field has changed in that way. Many other professions are coming to practice in the same area. The way that we think about projecting, the way that we think about evaluating, the way that we think about practicing is going to change. What we've done in the past with boxes, that's not going to work anymore with connected technology. Our organization as well needs to meet these challenges by having a stronger infrastructure. We need to have more visibility in terms of the new policies that are being formulated in Washington for connected technologies.
When we talked about creating organization and we struggled with the name American College of Clinical Engineering, I thought American means North and South America. The globe is bigger than just the US. And as they pass, we seem to be more and more connected.
As an organized, as an integrated technology, we need to do things different. So moving forward, we need to be working with other organizations, and ourselves are going to be changing.
Let's get out there and let's make things work. We need to do better. Engineers can lead the way.
I just like addressing the challenges in life. I'm really stimulated by the challenge of either something unknown or something that needs doing.
I like to see things happening right now. I like to have the application, the applied science, and realize that I created something, I solved something.
We have to keep the pressure on ourselves, our colleagues, and those coming into the industry to keep on learning.
The challenge of continuing the vision after creating a society is a very strong one, because what you are facing with is suddenly is, oh, you want to play the game? Well, here's the ball. Now we got the ball. What do we do? Where do we kick it? It reminds me the first time I came to the US and saw a football game, I thought the goalposts are upside down. I used to soccer, not to football. The same thing here. We got the ball, so where do we kick it? What do we do with it? And it was tremendously important not to turn this group of energy, of people, to the same complainer and whiners we were before, but to create something that would help us to make ourselves proud in what we are becoming. To stand up in the morning and say, I feel good because I'm a clinical engineer. Not because I feel bad because nobody pay attention to me, but I feel good because I'm creating something good today. I'm solving a problem today. I'm educating somebody that will follow me tomorrow. And that is what the biggest, in my opinion, the biggest challenge is. Continue the vision, continue to look forward and realize that just because we reach the first floor, it doesn't mean that we're on the roof. There are more floors to climb.